standard dose is 1500 international unit. Okay, so standard dose is how much? 1500 international unit. Okay, but then as I already told you, like 1% of the women will have a fetomaternal, 99% of the women will have a fetomaternal hemorrhage of 99% of the women will have a fetomaternal hemorrhage of less than 4 ml. Less than 4 ml. Okay. 1% of them will have a fetomaternal hemorrhage of more than 4 ml. Okay. 1% will have a fetomaternal hemorrhage of more than 4 ml. Within this 1%, please remember, within this 1%, 0.3% will have a fetomaternal hemorrhage of 0.3% will have a fetomaternal hemorrhage of more than 15 ml. So you understand the difference, no? See, we have minimum dose, we also have standard dose. Minimum dose is what? Minimum dose is 500 for term pregnancies. I am telling. For term pregnancies, for preterm pregnancies, we even use for abortions we even use less than 500, but for term pregnancies the minimum is 500. But the standard dose is 1500. Okay, minimum dose is 500, standard dose is 1500, and as I already told you, 1500 international units will neutralize 15 ml of fetal RBC. Okay, 1500 international units will neutralize 15 ml of fetal RBC. Okay, but this will cover only 99.7% because 0.3% of RH negative pregnancies or RH negative mothers will have a fetomaternal hemorrhage of more than 15 ml. Okay, so question is simple. What percentage of RH negative pregnancies are not covered by the standard dose of 1500 international units? 0.3% of RH negative pregnancies are not covered by the standard dose of 1500 international units. Okay, I am repeating the statement. What percentage of RH negative pregnancies are not covered by the standard dose of 1500 international units of NTD? It's 0.3%. Okay. Now, if you give even less than this, say you give only 500, the minimum dose. Okay. What percentage of women will be covered? What percentage of women will not be covered? Remember here, 99% will be covered. 500 international units. How much will 500 international unit cover? 500 international unit will cover 99%. Okay. It will not cover 1%. Okay. 1% of fetomaternal or 1% of, so this 500 international units will neutralize only 4 ml. Okay. 500 international units will neutralize only 4 ml. So now I understand your doubt. I mean 1500 is 15 ml. So 500 should be for 5 ml. That's what your doubt is, right? But the guideline says 500 is for 4 ml. Remember it this way only. 500 international units neutralize 4 ml. 1500 international units neutralize 15 ml. I know the numbers are not matching, but still you have to remember in the way it is mentioned in the guideline. Okay. So 1500 is for 15 ml, 500 is for 4 ml. This is what you have to remember. Okay. So don't ask me if 1500 is for 15 ml, 500 should be for 5 ml, right? No. Practically that is correct, but according to the guideline, it is not 5 ml, it is 4 ml. 500 international unit is for 4 ml. So how many RH negative women will have a fetomaternal hemorrhage of less than 4 ml? 99%. How many of them will have a fetomaternal hemorrhage of more than 4 ml? 1%. Okay. So what percentage of women would not be covered with a standard dose of 500 or minimum dose of 500 international unit? 1% uncovered. Okay. What percentage uncovered? 1% of the antenatal woman, 1% of the Rh negative women getting or receiving a dose of 500 international units would not be covered with the given anti-D. Okay. So these are the MCQs here. Fine. So next here, this is something about the dose. Other tests for quantifying fetal-maternal hemorrhage. What are the other available tests for quantifying fetal-maternal hemorrhage? We have two more tests. One is flow cytometry. One is flow cytometry and the other one is rotating technique. Okay. Apart from the KB test, the first test is KB test. The investigation of choice, the test of choice is KB test. Okay. Apart from KB test, we have two other tests. They are flow cytometry and rotating technique. Flow cytometry and rotating technique. Okay. So few more points on flow cytometry. Remember flow cytometry is more accurate. Flow cytometry is more accurate, but this is not the first choice test because flow cytometry is not universally available. Flow cytometry available only in limited places, and this is indicated only when Cleha-Bedke shows large FMH. Okay. This test is indicated only when Cleha-Bedke shows large fetal-maternal hemorrhage. Okay. Next is rotating technique. Okay. Rotating technique again is like flow cytometry. It's more accurate, but then it is not universally available and it is expensive too, and therefore rotating technique is not the first technique of choice. Rotating technique compared to flow cytometry is relatively simple, but then compared to Cleha-Bedke, it is not that simple. So Cleha-Bedke becomes the first choice. First choice test is Cleha-Bedke. Overall best is flow cytometry. Okay. So how much will 500 international units neutralize? 500 international unit will neutralize. 500 international unit will neutralize 4 ml of fetal-maternal hemorrhage. Okay. 500 international unit will neutralize 4 ml of fetal-maternal hemorrhage. Okay. That means how much will 125 international units neutralize? 125 international unit will neutralize 1 ml of fetal-maternal hemorrhage. So please be clear about this. 500 international unit will neutralize 4 ml of fetal-maternal hemorrhage. 125 international unit will neutralize 1 ml of fetal-maternal hemorrhage. So beyond the minimum dose, for every additional 1 ml of fetal-maternal hemorrhage, how much should you give? You have to give 125 international units of anti-D injection. You understand my point? Any doubts here? See, 500 is for 4 ml, 125 unit is for 1 ml. So for every additional 1 ml of fetal-maternal hemorrhage, say for example, you are treating a patient, you are the consultant obstetrician, and now as soon as the patient delivered, you have given 1500 international units. You have given 1500 international unit, which is the standard dose. Okay, thinking that this 1500 international unit will neutralize 15 ml of fetal-maternal hemorrhage. Okay, but then simultaneously you asked for a Cleha-Bedke test which shows the total quantity of fetal-maternal hemorrhage is 20 ml. Okay, Cleha-Bedke shows the total quantity of fetal-maternal hemorrhage is 20 ml. But then what you have given to the patient is only a dose which will cover 15 ml of fetal-maternal hemorrhage. So how much of fetal-maternal hemorrhage is left uncovered here? 5 ml of fetal-maternal hemorrhage is left uncovered. Okay, 5 ml of fetal-maternal hemorrhage is left uncovered. The difference between 20 and 15. Okay, now I am telling you for every 1 ml of fetal-maternal hemorrhage, you give 125 international units. So for 5 ml of fetal-maternal hemorrhage, you give 5 times 125, and that will be 625 international units. Okay, and this 625 international unit is in addition to the usual standard dose of 1500 that you give. You understand, no? Yes. So 1500 is for 15 ml. Beyond this 15 ml, for every 1 ml, beyond this 15 ml, for every 1 ml, you keep giving 125. Now, if you haven't given 1500, say in case, I'll tell you another example. Okay. In case you haven't given 1500 and in case you have given only 500, in case you've given only 500 international units of anti-D, okay, and now you're ordering for a KB test, okay. Now your knowledge on anti-D is this: 500 international units. 500 international units will neutralize how much? 4 ml of fetal-maternal hemorrhage. 500 international units will neutralize 4 ml of fetal-maternal hemorrhage. You've ordered for a KB test and the results shows that the actual fetal-maternal hemorrhage is 10 ml. The actual fetal-maternal hemorrhage is 10 ml. So, the dose that you have given to the patient has covered only 4 ml of fetal-maternal hemorrhage. What is left uncovered is 6 ml of fetal-maternal hemorrhage because the total is 10. Okay. So, for this 6 ml of fetal-maternal hemorrhage, that is left uncovered with a standard 500 international units, you add 125 ml for every 1 ml, okay. So, 125 multiplied by 6, okay. So, 125 multiplied by 6 will be 750 international units. So, here in this case, where you have given us, a minimum dose of 500 international units to the patient and the actual fetal-maternal hemorrhage is 10 ml. So, where the 6 ml of fetal-maternal hemorrhage is left uncovered or unneutralized, you will be giving an additional dose of 750 international units. This is a dose which is given in addition to the usual 500 international units, okay. So, this is how you have to calculate additional doses. You will be getting questions on additional doses of fetal-maternal hemorrhage. Just have this in your mind: for every 1 ml, 125 international unit has to be given. Either you give 500 or 1500, 500 neutralizes 4 ml, 1500 neutralizes 15 ml, you calculate the extra dose accordingly, okay. So, minimum dose. What is the standard dose? I already told you. Standard dose is 1500 international units, okay. Standard dose is 1500 international units. Under minimum dose we have 2, okay. Under minimum dose we have 2, okay. What is the minimum dose for less than 20 weeks pregnancy and what is the minimum dose for 20 weeks and above pregnancy, which is 20 weeks and above, okay. So, less than 20 weeks means it almost comes under abortion, right, okay. Here the minimum dose is, for less than 20 weeks, the minimum dose is 250 international units, and for a viable pregnancy, 20 weeks and above means viable pregnancy, right. For a viable pregnancy, the minimum dose is 500 international units, okay. So, for less than 20 weeks, the minimum dose would be 250 international units, and for 20 weeks and above, the minimum dose should be 500 international units. This is again an MCQ. So, we've read some MCQs since the beginning of, in this GTG guideline. What all can be asked? So, what is the test of choice to quantify fetal-maternal hemorrhage? Answer is CLI-Habit K, okay. And the minimum 500 international units, how much will it cover? It will cover 4 ml. The standard 1500 international unit dose, how much will it cover? It will cover 15 ml of fetal-maternal hemorrhage, okay. So, next question is this: the percentage of women not covered by minimum dose, 1%. Percentage of Rh negative women not covered by standard dose, 0.3%, okay. So, how will you calculate? Every 1 ml of fetal-maternal hemorrhage will require 125 international units of anti-D in addition to the usual dose that you give, okay. So, you know how to calculate. What is the minimum dose for less than 20 weeks? It's 250 international units. Minimum dose for 20 weeks and above, it is 500 international units. Standard dose, 1500 international units, okay. Regarding the timing, when to administer, the site, where to give, okay. When to administer? As soon as the sensitizing event occurs, okay. Ideally within 72 hours. So, when should you administer? As soon as the sensitizing event occurs. As soon as the sensitizing event occurs, okay, ideally within 72 hours. Ideally within 72 hours. Okay, as soon as the sensitizing event occurs, or ideally within 72 hours. What if the patient has not received the dose within 72 hours? If she has not received the dose within 72 hours, then it can be given up to 10 days. It is justified, it can be given up to 10 days, okay, can be given up to 10 days. The ideal site is deltoid, okay, ideal site is deltoid, it has to be given intramuscular, okay. Why deltoid? Because it is wise to give it intramuscular. Of course, we have IV preparations, but then intramuscular is the usual preferred route, okay. Why not the gluteal region? Because gluteal region has more fat when compared to the deltoid region, and the gluteal region, when you inject in the gluteal region, there are chances that it would get deposited subcutaneously, and in that case the absorption rate will be less, okay. So, in order to avoid subcutaneous injections and to make sure that the injection is given in the muscle, you give it in the deltoid. So, apart from intramuscular, what are the other available routes? The other available routes are subcutaneous and IV preparation, okay. The usual preparation is IM, okay. The recommended preparation is IM, but there are situations where we can give IV or subcutaneous, which I will tell you, okay. So, now in case the woman has a bleeding disorder, okay, what would you do in case the woman, because IM injections are preferably avoided in bleeding disorders, right? Because IM injection is where you prick the person very deep, you go to the muscle level, so you prick them very deep. There are chances that the muscle might bleed, okay, and there might be hematoma inside the muscle. So, as far as possible, you have to avoid IM injections, giving IM injections for a lady with bleeding disorder. And in that case, what would you do? You prefer giving either subcutaneous route or IV route, preferably IV route, okay. So, before you give this anti-D, should you obtain consent? Yes, consent has to be obtained. Consent has to be taken before you give anti-D, and it has to be documented in the case sheet, okay. Consent has to be obtained and it has to be documented in the case sheet. Sometimes women would not strongly express the D antigen, they would weakly express D antigen, and in that case you would have a confusion on whether to consider this lady an Rh negative lady or an Rh positive lady. Remember, there is no harm in giving anti-D even for an Rh positive lady, because the amount of anti-D that you give will just neutralize 15 ml of Rh positive cells, which would not harm the lady, okay. But in case she is Rh negative, in case she is a weak responder and she is Rh negative, and if you haven't given, then it would lead to a bad obstetric career for her okay. So, in that case, weak expression of Rhd, what is the ideal thing to do? Weak expression of Rhd, weak expression of Rhd for all practical purposes, you consider this lady as an Rh negative lady and don't fail to give her anti-D, okay. So, just give her the routine prophylactic dose, okay. Just give her the routine prophylactic dose, okay. So, this is about the timing and the site. So, when should you give? As soon as the sensitizing event occurs or within 72 hours. It can be given up to 10 days. Preferably, it has to be given IM. Subcutaneous and IV routes are also available. For women with bleeding tendencies, it's better given IV, okay. And consent has to be taken. It has to be documented in the case sheet. And for women with weak positive Rhd antigen, you consider them as Rh negative and don't forget to immunize them, okay, with anti-D. Anti-D has to be given even for women with weak positive Rhd, okay. So, this is about the timing and the site, okay. Regarding miscarriages, So we all know miscarriage is one sensitizing event, right? So anti-D has to be given, but there are certain miscarriages. I mean, there is one condition where you don't have to give anti-D. So what condition is that? Okay. Now for spontaneous miscarriage before 12 weeks. Spontaneous miscarriage before 12 weeks, that means first trimester spontaneous abortion where there was no instrumentation, okay. That means it's a complete abortion where suction, evacuation or dilatation and curettage have not been performed, okay. So spontaneous miscarriage before 12 weeks with no instrumentation is the condition where anti-D can be avoided, okay. This is the only miscarriage where anti-D can be withheld or anti-D can be avoided. Anti-D is not required, okay. If any of these conditions are not satisfied, like say it is not a spontaneous abortion, say it is a medical termination of pregnancy, induced abortion, or the gestational age is more than 12 weeks, or instrumentation has been done, like say suction evacuation has been done, okay. If any of these are there, then that becomes an indication for anti-D, okay. So now let's see other examples, okay. What do you do for second trimester abortion? Second trimester abortion, regardless of whether it's medical abortion or surgical abortion, okay, regardless of whether it is spontaneous abortion or induced abortion, if the gestational age is more than 12 weeks, there is no excuse for anti-D, okay. If the gestational age is more than 12 weeks, there is no excuse for anti-D. So anti-D has to be given in this condition. I'm just writing it here. Anti-D, yes, it has to be given, okay. Yes, it has to be given for second trimester abortions, okay. Next is surgical evacuation. If surgical evacuation has been performed regardless of the gestational age, if surgical evacuation has been performed, then yes, anti-D has to be given again, okay. So surgical evacuation means suction evacuation or dilatation and curettage. In the first point on miscarriage, I told you, you can avoid giving anti-D if only there was no instrumentation. Instrumentation means surgical technique, okay. So yes, if surgical techniques, surgical technique has been used, then yes, it is an indication for anti-D, okay. Next is medical termination of pregnancy, medical evacuation, say for incomplete abortion. Either you gave her tablet misoprostol or prostaglandin for incomplete abortion, or you used medical methods for medical termination of pregnancy. It was an induced abortion, okay. So for all induced abortion, or in other words we say MTP, no? For all induced abortion or MTP, yes, anti-D has to be given, okay. Next question is for incomplete abortion. Supposing say it was a spontaneous abortion but it was incomplete, okay. In that case again, yes, it has to be given, okay. Incomplete, okay. Incomplete abortion, regardless of whether dilatation and curettage was done or suction evacuation was done or she was treated with the tablet misoprostol, that means medical abortion was done. If it was incomplete and if some intervention was done, then again, yes, anti-D has to be given, okay. Again, yeah, anti-D has to be given, should be considered, I mean, yes, okay. So these are conditions where anti-D has to be given. Next is about threatened miscarriage, okay. Threatened miscarriage is where the fetus is still alive, right, okay. So what do you do in case of threatened miscarriage? Threatened miscarriage in the first 12 weeks is where anti-D can be avoided, but if the bleeding is continuous, you have to give, okay. So threatened miscarriage after 12 weeks. threatened miscarriage after 12 weeks. What should you do? I told you, any kind of abortion, say it is threatened or incomplete or complete, once the gestational age is more than 12 weeks, anti-D has to be given. And yes, here again, threatened miscarriage after 12 weeks, anti-D has to be given. Okay. So what will you do if the bleeding is continuous? Continuous bleeding after 12 weeks. Okay. Continuous bleeding after 12 weeks. Here again anti-D has to be given, but because the bleeding is continuous, the anti-D that you give would not work beyond a certain point of time, and therefore this lady will require repeat doses of anti-D. Anti-D has to be given at 6 weekly intervals. That is the perfect way to manage this patient. Okay, give anti-D at 6 weekly intervals. Okay, give anti-D at 6 weekly intervals. Okay, give anti-D at 6 weekly intervals. Okay, fine. If there was mild bleeding before 12 weeks which stopped without any intervention, what would you do? Okay, mild bleeding before 12 weeks, which stopped, okay, without any intervention. What would you do in this case? Yes, anti-D can be avoided. Okay, in this case, avoid anti-D. Okay, so under threatened miscarriage, there is only one situation where you will not give anti-D, and that is a threatened abortion before 12 weeks where the bleeding has stopped by itself. Okay, repeated or heavy bleeding before 12 weeks, again you have to consider giving anti-D. Okay, repeated bleeding before 12 weeks. What would you do? You have to consider giving anti-D. For all exam purposes, take it as an indication to give anti-D. Okay, take it as an indication to give anti-D. Okay, so now we're seeing various conditions, various types of abortions, and we're discussing on where to give, where not to give. Okay, for a case of complete abortion, okay, for a case of complete miscarriage, complete abortion, where will you not give anti-D? If it is a case of spontaneous miscarriage before 12 weeks, instrumentation has not been used. Okay, so this is where you will avoid giving anti-D. Okay, so in case it's an induced abortion, or in case the gestational age is more than 12 weeks or instrumentation has been done, you will be giving anti-D. Okay, for all second trimester abortions, anti-D has to be given. Surgical evacuation, yes, it has to be given. For induced abortion, for MTP, yes, you have to give. For incomplete, again, yes. Okay, so for threatened miscarriage, where can you avoid? If the gestational age is less than 12 weeks and the bleeding has stopped by itself and the pregnancy is continuing well, there you can avoid. For all other conditions, you have to give, like say continuous bleeding before 12 weeks, bleeding after 12 weeks, or continuous bleeding after 12 weeks, yes, you have to give anti-D. And in case there is continuous bleeding after 12 weeks, it's wise to give anti-D at 6 weekly intervals. Okay, 6 weekly intervals. Okay, next important MCQ is this, ectopic. Very, very important MCQ. What would you do for ectopic pregnancy? Would you give anti-D for ectopic pregnancy? Answer is yes, even if the gestational age is less than 12 weeks. This is the main difference between miscarriage and ectopic. In case of miscarriage, if the gestational age is less than 12 weeks, you have certain relaxations, you can avoid anti-D. If it was spontaneous, complete, no say instrument has been used. In case it's more than 12 weeks, you will give. This is for abortion, right? But in case it's ectopic, please remember, regardless of the gestational age and regardless of the management, regardless of the technique you've used, you have to give anti-D. Anti-D should be given. Anti-D should be given for all cases of ectopic. Anti-D should be given because the chances of fetal-maternal hemorrhage are more with ectopic pregnancy than abortion. Okay, anti-D, because ectopic is somewhere in the tube, most of the time in the tube, and it's a highly vascular area, and once it ruptures, the chances of fetal-maternal hemorrhage are high. Okay, so anti-D should be given regardless of the gestational age and the treatment, the management technique. Okay, therapeutic termination I already told you. Termination of pregnancy, yes, they are also regardless of gestational age, regardless of, for all cases of MTP, yes, you have to give the same. Okay, anti-D should be given for all medical termination of pregnancy. Okay, so what are the various sensitizing events during pregnancy? Beginning of this session, I told you certain points which is associated with massive fetal-maternal hemorrhage. Don't confuse that list with the list that I am going to tell you now. The list that I am going to tell you now is for those events which lead to sensitization. It may not be massive, but the one that I told you earlier is the list that leads to massive fetal-maternal hemorrhage. Okay. So what are those conditions that lead to, the sensitization during pregnancy, sensitizing events during pregnancy? Okay. What are those sensitizing events? What are those sensitizing events during pregnancy? Okay. Invasive prenatal diagnosis. Invasive prenatal diagnosis. It can be any procedure, diagnostic procedure during pregnancy, like say chorionic villus sampling, amniocentesis, chordocentesis, intrauterine transfusions and all these. Okay. Any other invasive procedures? Like what? Insertion of shunt, embryo reduction, laser, all these things. Laser, embryo reduction, insertion of shunt and all these. Okay. Next is what? Antepartum hemorrhage. So more likely to be abruption or even placenta previa. Antepartum hemorrhage. Okay. Next is external cephalic version. It includes even attempted version. Okay. Including attempted version, external cephalic version including attempted version. Okay. Any abdominal trauma. Okay. Fetal death, IUD. Okay. And recurrent vaginal bleeding. After 20 weeks. Okay. All these are potential sensitizing events that can occur during pregnancy. Invasive prenatal diagnosis like chorionic villus sampling, amniocentesis, chordocentesis, laser techniques, embryo reduction, antepartum hemorrhage, ECV, abdominal trauma, fetal death and recurrent vaginal bleeding. Okay. All these are indications for anti-D regardless of when the patient received the last routine antenatal anti-D prophylaxis. We give routine antenatal anti-D prophylaxis, no, during pregnancy. Apart from this, all these sensitizing events should receive anti-D during the antenatal period, and this dose of anti-D that you give for these sensitizing events will be a dose that is given in addition to the routine antenatal anti-D prophylaxis. Okay. So before 20 weeks, how much would you give in these cases, in these sensitizing events? If the gestational age is less than 20 weeks, you would be giving 250 international units, and if the gestational age is more than or equal to 20 weeks, if it is more than or equal to 20 weeks, you will be giving 500 international units. This is applicable for abortion too. Please remember, even for abortions and ectopic, this amount, the dose is applicable. Okay, so what is the dose? Gestational age less than 20 weeks, 250. More than or equal to 20 weeks, 500, regardless of whether it's abortion or ectopic pregnancy or any sensitizing event or whatever. Okay, so now in addition to this, 500 international units for gestational ages more than 20 weeks, for gestational ages beyond 20 weeks, you will also be doing a Kleha-Betke test. Okay, for gestational ages more than 20 weeks, you will also be doing what? Clay habit K. Okay, you will also be doing a clay habit K test. Okay, recurrent vaginal bleeding after 20 weeks. Again, here you will give anti-D as I told you, either 250 or 500 depending on the gestational age. Here it's after 20 weeks, so you will be giving 500. But then whenever there is recurrent bleeding, please remember, whenever there is continuous bleeding, you have to keep repeating the anti-D at 6 weekly intervals and keep repeating the KB test at 2 weekly intervals. Okay, so here you will give anti-D 500, recurrent on and off bleeding. You will give anti-D 500 international units. Apart from this, you will also be doing a KB test at 2 weekly intervals. Okay, you will also be doing KB test 2 weekly, and you will also be repeating anti-D 6 weekly. Okay, repeat anti-D at 6 weekly intervals. Okay, repeat anti-D at 6 weekly intervals. So this is all about how to manage sensitizing events. Okay, so depending on the gestational age, you will give either 250 or 500, and depending on whether the bleeding is continuous or not, you will be deciding on the repeat doses. Okay, fine. So for recurrent vaginal bleeding, we discussed that repeat doses have to be given. Okay, every 6 weekly. Repeat anti-D every 6 weekly. Okay, in case you have a suspicion of whether the anti-D that you're giving is inadequate, or when you perform a KB test, the KB test still shows fetal red cells, unneutralized fetal red cells, what would you do? You will have to give an additional dose of 500. Okay, in this case, give an additional dose of 500 international units if the KB test still shows fetal red cells in spite of giving the routine anti-D 500 international units every 6 weekly. Okay, I hope you're not confused, you have understood. Like say for any sensitizing event, apart from the routine anti-D prophylaxis, routine antenatal anti-D prophylaxis, you will be giving an additional dose of 250 international units if the gestational age is less than 20 weeks and 500 international units if the gestational age is more than 20 weeks. And in case the bleeding is recurrent, there is recurrent vaginal bleeding after 20 weeks, you will be repeating this 500 international units every 6 weekly, and simultaneously you will be performing a clay habit kit test to see if the dose that you have given is adequate. And in case you find fetal red cells in spite of giving 500 international units 6 weekly, it means that the dose is inadequate, and this becomes an indication for another 500 international units of anti-D injection. Okay, so this is about sensitizing events. Fine. So we'll now discuss about routine antenatal anti-D prophylaxis. Okay, in short we call it RAADP. Okay, what is RAADP? Routine antenatal anti-D prophylaxis. Routine antenatal anti-D prophylaxis. Okay, so what would we usually do when a patient comes to us in the booking visit? We usually perform an ICT, right? So we discussed Rh negative pregnancy. We also discussed certain points that were mentioned in the textbook of Williams, and there we saw the ICT has to be done at booking visit, ideally at before 12 weeks, say booking visit, and at 28 weeks. Okay, so ICT at booking visit, okay, and 28 weeks. ICT at booking visit and 28 weeks would be ideal. So what do you mean by sensitized women? If ICT is positive, it's kind of, the pregnancy is sensitized, right? So in case ICT is positive, it means the pregnancy is a sensitized pregnancy. Is there any point giving anti-D in the sensitized pregnancy? There's no point giving anti-D in the sensitized pregnancy. Okay, so if ICT is positive, there is no use giving routine antenatal anti-D prophylaxis. Okay, if ICT is positive, there's no point in giving this routine antenatal anti-D prophylaxis. Okay, routine antenatal anti-D prophylaxis or prophylactic anti-D should only be given for women with negative ICT. Okay, so in case the woman is non-sensitized, yes, you can give, and the usual dose will be either 500 or 1500. So the guideline says either you opt for a 2-dose technique or a single dose technique. okay, 2-dose or a single dose technique. So in case it's a 2-dose technique, how are we going to give it? 2-dose technique is where you will be giving 500 international units at 28 and 34 weeks, okay. 500 international units, one at 28, 2 doses of 500 international units each, one at 28 and the other at 34 weeks. And in single dose technique, you will be giving 1500 international units, okay. In single dose technique, you will be giving 1500 international units, 1500 international units at 28 weeks, okay. So 500 international units, 2 doses of 500 international units, one at 28 and the other one at 34, or a single dose of 1500 international units at 28 would be the appropriate dose for RA-ADP, okay. So in case there is a sensitizing event, say for example, you give the routine antenatal, you've given the routine prophylactic dose at say 28 weeks and the lady comes with abruption at 30 weeks, what would you do? You have to give additional dose, you have to give the sensitizing dose. So we saw what the sensitizing dose is, right? For less than 20 weeks it's 250 and for more than 20 weeks it's 500. So whatever is the sensitizing dose, you have to give that sensitizing dose with every sensitizing event regardless of when the patient received the last RA-ADP, okay. So in case the woman received the last RA-ADP at 28 weeks and this patient comes with a sensitizing event at 30 weeks, regardless of this 2 weeks gap, okay, regardless of the minimum gap, this sensitizing dose has to be given, okay. Sensitizing event should be covered with either 250 or 500 international units regardless of routine antenatal anti-D prophylaxis, okay. For how long does it persist in the circulation? So you give passive immunization, you give anti-D injections for how long? Does it persist? It persists for 8 weeks, okay. The anti-D that we administer, the anti-D that we administer persists for 8 weeks in the circulation, okay. So in this 8 weeks period, after a dose of anti-D, if you subject the woman for an indirect Coombs test. Indirect Coombs test is a test to see if anti-D is present in a lady's circulation, right? Now you have given this anti-D from outside, so obviously this ICT would detect anti-D. So obviously this ICT would be positive, okay. So when this ICT becomes positive, there are two possibilities. One is it could be due to passive immunization, or the other possibility is that it is due to true sensitization, okay. Now a positive ICT, so whenever ICT is positive, a positive ICT can be due to passive immunization. Passive immunization means the anti-D injection that you give, prophylactic dose of anti-D that you give, or it can be due to immune reaction. That means the lady herself is sensitized and she started producing anti-D by herself, okay. So in these two conditions, ICT can be positive. But remember, in case of passive immunization, the ICT will usually be positive in low titers, whereas in immune sensitization, the ICT would usually be positive in high titers, okay. So this is one way of differentiating it. And the other way is to elicit history from the patient on whether she took any anti-D in the last 8 weeks or so, okay. But still remember, whenever in doubt, okay. Now why do we after all do this ICT? To decide on whether to give anti-D or not, because routine anti-D prophylaxis has to be given at 28 weeks of pregnancy. In case this ICT is positive, you are in a dilemma on whether it is passive ICT positivity or immune positivity. Now in this case, you have to give anti-D, okay, regardless of what type it is, okay. So whenever in doubt, give anti-D, that's what I say, okay, because the guideline routinely says if it's immune ICT, there is no point giving anti-D. So if it is a clear-cut immune ICT, that means there is no history of immunization in the past and the ICT is positive in high titers, then there is no point that you don't have to give. In case there is a doubtful history of immunization in the past, the lady is not able to exactly recall on what she got, okay, there is a doubtful history of immunization in the past and ICT is positive in low titers. So both of these together are in favor of what? Passive ICT, passive positivity, right? So in this case, you have to give anti-D, okay? For the benefit of doubt, you have to give anti-D. And the next is on passive immunization and DCT. What does immunization do to DCT? Direct Coombs test. See, direct Coombs test is where the antigen and the antibody react, and the anti-D injection that you give is against the D antigen that is present on the red cells, right? So if say the red cell has D antigen on its surface, and in the circulation you also have anti-D, this anti-D would bind to this D antigen, and in that case DCT would become positive. Okay. Now you giving it to an Rh negative lady, assuming that she has no Rh positive antigens, no D antigen on the red cell, and this anti-D would only neutralize the fetal red cells which is supposed to have D antigen on its surface. But then by the time you give anti-D injection, there would be some fetal RBCs present in the maternal circulation, and these fetal RBCs would bind to the anti-D that you give to convert the direct Coombs test positive. Okay. So in that case, DCT would become positive. So when you immunize the mother, when you give passive immunization to the pregnant lady by this routine antenatal anti-D prophylaxis, what would happen to DCT? DCT would become positive. Okay, DCT would also become positive. So this can convert ICT positive. This can also convert DCT positive. What? The routine anti-D that we give. The routine antenatal anti-D prophylaxis can convert the ICT positive, can also convert the DCT positive. Okay, so passive immunization and fetal hemolysis. So does it lead to fetal hemolysis? Does it cross the placenta and destroy the fetal RBC? No. Okay, why doesn't it cross the placenta and destroy the fetal RBC when it is actually capable of doing that? Because the injection that you give has very less quantity of anti-D, not adequate enough to cause fetal hemolysis. Rather, the amount of red cells that would cross the blood placental barrier and reach the maternal circulation would be very less, adequate enough to be neutralized by the minimal dose of anti-D that you give. You understand? So the anti-D that you give, the injection that you give, though it is capable of crossing the placenta, would not cross the placenta because all the anti-D that you give would be utilized to neutralize the red cells that come from the fetus to the mother, rather than this anti-D going from the mother to the fetus to destroy the fetal RBCs. Okay, so does it cause fetal hemolysis? Answer is no. It does not cause what? Fetal hemolysis. Okay, after a passive immunization, okay, when I say passive immunization, I'm talking about what? I'm talking about routine antenatal anti-D prophylaxis, the anti-D that we give at 28 weeks, the anti-D that we give at 28 weeks. Can it turn the ICT positive? Yes, it can cause. It can make the ICT. Can it convert ICT positive? Yes, it can. Due to DCT, it makes the DCT positive. Does it cause fetal hemolysis? No, it does not. It does not lead to fetal hemolysis. These are the three important MCQs you have to know. It can make the ICT positive. It can convert DCT positive. It does not lead to fetal hemolysis.